Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friends. Welcome back to this week's episode of the Healing Pain Podcast. Today, we're joined by Dr. Ellen Zambo Anderson, who is an associate professor in the Doctorate of Physical Therapy program at Rutgers University. In addition to earning a PhD in health sciences, she's an assistant director of the Rutgers Community Participatory Physical Therapy Clinic and serves as the Special Olympics Global Advisor for Young Athletes. Dr. Anderson is co-author of the textbook Complementary Therapies for Physical Therapy and co-owner of Yogi Anatomy, a company that provides continuing education on the topics related to complementary approaches for managing well-being, health, and function. On today's episode, we examine professional burnout in the physical therapy profession and provide suggestions for individuals and institutions to address and decrease burnout. Okay, important topic for all of us in the profession of physical therapy and other health professions as well. So make sure to share this episode with your friends and colleagues. Okay, let's get ready and let's meet Dr. Ellen Zambo Anderson. Hi, Ellen. Thanks for joining me this week on the podcast.
Hi, Joe. It's great to be here.
I'm excited to chat with you. The topic of burnout in physical therapy and pain care is not something we've covered in depth. And I know it's something you've conducted some research around. So I'm excited to talk to you just based on some of your research and, of course, just talking, one colleague to the next in the same profession and how burnout may or may not impact us. Mm-hmm. I think a good place to start out is to just define burnout. I think most of us have felt burnout at one point or another, or thought we may be heading toward burnout. But how is burnout defined?
Okay, so burnout, technically speaking, has a definition that comes from Maslich. And that definition has three parts. That burnout is comprised of emotional exhaustion, depersonalization, and a sense of personal accomplishment. And so it has been typically used in healthcare providers, and that's where it originated because back early when this definition was being developed, it was observed in healthcare providers because they were working with people who had complex issues. And the reserve or the fortitude or the skills that were necessary from the provider meant that you were constantly encountering people with very complex and almost life-altering conditions. And that could be very challenging. And so Maslich describes burnout as not one entity, but it has these various components. We now in the vernacular use burnout, and maybe we call it like with a lowercase b, as interchanging it with I'm stressed out. Mm-hmm. But burnout with a capital B is more of a psychological syndrome, if you will.
And of course, we can measure those three aspects that you just mentioned. Is that right?
That's right. So using the Maslich Burnout Scale, it's not perfect, as most scales aren't perfect, but there are questions that are asked that get categorized according to which one of those categories. And using that scale, for someone to officially have burnout, they need to be high in emotional exhaustion, high in depersonalization, and low in their sense of personal accomplishment.
I've seen that. It's a self-rated score. I've seen it in self-rated measure. I've seen it in the literature quite often.
Yes, it is considered the gold standard, it's used in more studies than any other burnout scale.
Yeah. Mm-hmm. However, when I was doing some research for this episode and starting to look through the literature, I noticed there seemed to be more studies on physicians and kind of nurses, I think, the most. And then as we trickle our way down to our profession of physical therapy, I didn't notice a lot. Would you say that's the case?
That is definitely the case. So when I started to do this work now about 5 or 6 years ago, The most recent burnout studies in physical therapists were like 20 years. So we're talking a really long time ago. And some of them use Burnout Scale, and some of them didn't. What I think we need to be aware of in the literature is that not all authors are reporting on all elements of the burnout scale and using that. So the headline might be, physicians have, 80% of physicians are burnt out. And when you read the paper, you realize that they only took the emotional exhaustion piece. And 80% of physicians are emotionally exhausted, but fewer of them actually hit the categorization of true burnout. And so what I was interested in also is there a relationship between, say, emotional exhaustion? Because that's maybe what people are describing when they say, I'm burnt out, right? And that relationship of that score to a stress measure. So, for example, using the perceived stress score.
So why would someone just have one component of that inventory? Is it just because someone didn't have enough time or money to contribute with regard to the study, or are they just interested in that one component specifically?
Yeah, so they probably did the whole burnout inventory, but it's a little bit sexier to talk about, the high numbers of quote unquote burnout. And so you'll pick one component or two components perhaps and talk about the percentage of that. And so when we take a look at physical therapists, what I learned was that about a third have high emotional exhaustion. About 13% have burnout. So we don't want any one of our colleagues to be burned out. But if we take a look at a third having high emotional exhaustion, that is not a good place to be when it comes to our own well-being, and also when it comes to patient care. Because what happens with high stress or high burnout is that we see that there's a compromise in patient care. Mm-hmm. There's less reserve, there's less energy for that. In the case of burnout, if there's some depersonalization, it means that you're kind of treating that person as a case. You're trying to initially maybe use that as a coping strategy to not get too involved, but then you completely dissociate from that person. And when that happens, patient care suffers because of that.
And do you have a statistic related to that depersonalization scale from the work you've done?
So interestingly, when it comes to depersonalization, it's only a few percentage points. It's for physical therapists, it's down around 3 or 4%.
Wow, that's so interesting.
It is really interesting. And so this is personal opinion, in looking across the data when it comes to physicians versus physical therapists. And the low depersonalization is also found in occupational therapists. There's not very many studies on that profession as well. But I think it has a lot to do with the amount of time that we spend with our patients, because we get to know them a little bit more richly and deeply. We often have connections with at least one family member. And we're working on remediation and rehabilitation for them going back into their life. We have a direct effect on their lifestyle and their functional well-being. Whereas I think that physicians will have an understanding of their general health, but they haven't worked quite as intimately with patients in some of the areas of restoration of function.
Really interesting. So we're low on the depersonalization and we're high on the emotional exhaustion part.
And we're high on the emotional exhaustion part, yes.
Yeah, that's so interesting. It's interesting for people to think about and reflect on their own experience and what they're experiencing in the clinic. And you did this work a little while ago. I know you're continually, you have your hands in this work. The reason, of course, people want to know, why am I burnt out? Like, what's the reason? And has that changed over the course as our programs and workplaces have changed over the past 20 years, from a bachelor's to a master's to a DPT, and
Right.
all these, our profession is just so active and moving and changing quite frequently.
And so vastly different, yes. I did not ask the question about why, because the study was really looking at, do we have burnout, first of all, in our profession? But I can tell you what we know from other healthcare providers, and it was consistent in some of the earlier work that was done with physical therapists. And that is, one factor is not enough supervisory support in the workplace. And so that is a big factor. And so I'm going to sort of talk about the institutional factors first. Another one is the requirement to see more patients, and the relationship of that with autonomy. So when you see more patients, it's very difficult to be able to be completely autonomous, because you want to proceed with certain interventions or have time to be able to make adjustments with your plan of care, but you feel as though you're restricted because there's another patient coming along. And so it impedes your autonomy. Another thing is the redundancy of documentation. So everyone knows that documentation has to happen, but it's the documenting for 4 different entities or in 5 different ways, or doing a flow sheet and your note and the billing, that type of thing. And another big stressor in the workplace is the financial concern relative to reimbursement. And so, is it calls to the insurance company? Is it the communication with the patient? So the influence of the finances over what you think is best for your patient is another stressor in the workplace. So those are institutional stressors, if you will, institutional reasons that contribute to a therapist burnout. And you can see how that's likely consistent across all healthcare providers.
Yeah. And then within our profession, there are different clinical settings.
Correct.
Pediatrics, outpatient orthopedics, geriatrics, academia.
Right.
Is burnout consistent across those, or is there a place I can be less burnt out, Ellen?
In academia, yes. Okay. So there is a lesser incidence of burnout in academia. And you might be able to guess that the highest is going to be in long-term care facilities, where it's long-term care and subacute rehab. Now, I know that a lot of outpatient therapists who are working in those settings, where the intensity is really high because there's a demand of so many patients per day and so little space for communication documentation. So you might expect that they come out on top, but absolutely across the board, the two that bubble up is the worst in being in long-term care and the best is being in academia.
The long-term care makes sense to me to some level, because I can see high emotional exhaustion there, actually.
Right.
Why in academia it's the lowest?
I think in large part because there's a fair amount of autonomy. And the fact that you're creating intellectual property that can be very satisfying from a sense of personal accomplishment. And there may be departments or chair people that are, terrible to work for, but by and large, there's a very supportive collegial environment because faculty need to work together. They need to collaborate in research, but they also need to collaborate in rendering a curriculum that is important for the next generation of physical therapists. So there's a concerted commitment to that effort.
I'm surprised there's not more on burnout, because when you look at burnout from an institutional perspective, as you mentioned, when people burnt out, they don't stay with the same job, or if they're in the job they're in, as you mentioned, their performance is lower. So it does have a bottom line dollar connected to it in some way, which in healthcare, we're very conscious of making the dollar go further and things like that.
Right. And that is one area of concern, is that not only is burnout associated with decrease in patient care, but we also see that it is correlated with people leaving the field. And so if you think about turnover and what it costs to train people and so on and so forth, and then what it means to the profession if people are leaving because of burnout. So the cost can be quite high to the profession, to the institution, and then think about the individual.
Yeah, replacing an employee is very expensive.
Yes.
And it's also a time-consuming process for human resources and things like that.
Absolutely.
What would your recommendations be? Let's say a hospital administrator said, "Hey, we noticed that our turnout is really high in our PT staff, and we did this little study and they're burnt out, but we don't know how to help them and support them."
Right. So I would do a two-prong approach. I would look at institutional factors that contribute to burnout, and then I would do some assessment regarding the personal factors. And so the Maslach burnout inventory can give you a little bit insight of those domains, right? But it's not giving you a lot of information about how to get better or how to fix the emotional exhaustion, or about how to fix the depersonalization. But in thinking about a relationship between emotional exhaustion and stress, you can look at, say, perceived stress in your staff, note that the stress might be high, and then what strategies can an individual take, or can an administrator take, to help individuals become more resilient, to help them manage stress. And so what is speculated is that you have people who can be two people in the same institution, and one literally burns out with a capital B, and they're gone, and somebody else stays. So what's the difference between those two? Right? And that difference, it's the same institutional factors. It comes down to the person. What kind of coping strategies, what kind of mechanisms does that person who stays put into place? And so what my research showed, and this is consistent in other papers, is that there tends to be less burnout in older therapists who have been practicing 25 years or longer than younger therapists. And the hypothesis is that they just figured out how to deal with it, right? You just found a way to be able to cope. And good news for our therapy profession, it wasn't a coping strategy that was dysfunctional, right? Because if it was dysfunctional, then you would depersonalize and you would just sort of go through the motions. But we find that in our profession, we have really low depersonalization. So we found a way to be able to deal with all of those stressors, the stressors that the patient gives us and the stressor from the institution. So if I was advising an administrator, I would say you really need to take a close, hard look at, the role that your supervisor is playing in support, do you have efficient systems in place? And now, what kinds of rewards, what kinds of space are you giving? What kinds of benefits are you providing for people to find their way to navigate their stress, to improve their health and well-being?
So there's a part there where there's responsibility of the practice or the institution.
Mm-hmm.
And then it sounds like there's also a little part of self-reflection on the clinician, the individual, and
Mm-hmm.
to look at what type of coping strategies they have to deal with. Really, we're talking about mental health in many ways.
Absolutely. And as we've all experienced, we could be humming through life, dealing with various stressors, and then something catastrophic comes along and we're unable to regroup. So what does the institution do to help an individual in that situation, right? But we also know that there's times when people are going along and it just takes one more straw to break the camel's back, right? The supervisor, the institution is not going to know that, but the individual might with, appropriate reflection, really being able to get a sense of where they are from a mental health standpoint.
So with regard to the person who has maladaptive coping, I guess two questions are coming up for me. One is the supervisor plays an important role. And that's interesting to me because I provide a lot of peer review and peer support for professionals. So I'm always it's always interesting to me to see how much peer review and peer support people need. If you have any idea with regard to that. And then what can an individual do who's recognizing, hey, I think I fall into that emotional exhaustion category. Mm-hmm. What can I do to rev up my own personal coping mechanism so that I can, buffer some of this burnout?
Yeah. So ask me the first question again.
So the first question is with regard to supervision.
Okay.
How much, or is there, kind of frequency, intensity, so to speak? So it's like number of hours per week spread out over a course of time. I think research been done in that area.
Yeah. I don't know about like dose, if you will, but the idea of having time to meet with a supervisor, meet with your employee, to talk about exactly what we were just describing. What are the stressors? How do you see yourself in this workplace? Are there areas where you would like to grow and develop? What are the areas? Tell me what's happening as far as frustration or your most frustrated day. What do you think the triggers are about, for that? And the supervisor shouldn't feel as though they have the answers. Right? Because if you think about what a coaching session is all about, you ask those questions, the person, you give them space to respond to that, and then they hopefully find their own way. And I think supervisors are often hesitant to go into that conversation because they feel as though they have to have the answers, because they feel as though they have to fix it. But the recipient, the worker, really wants to be heard. More often than not, they're not looking for a fix. Sometimes if they're really boiled over and angry, they want to fix, but most of the time they just want to be heard. And the research supports that as well. The challenge to the supervisor also is that you don't make a promise that you can't keep. So don't offer anything. Don't try to fix something and then not be able to come through with it. So it takes reflection on both entities, both the worker and the supervisor, to do that. The second question was about what can you do for yourself?
Yeah, that internal process that so many people struggle with, especially in pain care, because we know the burnout is high amongst all pain professionals.
Oh, yeah, absolutely. So I think for the individual, it really does come down to finding a way for you to be able to identify your stressors and what are your resources. Where are your strengths to be able to effectively deal with the stressors? And for some of us, it may take us going to a counselor. It may take talking with someone else to really be able to explore that. But I think that most of us could sit down and we could say that I like to use the phrase, like, I became, irrationally irritated, right? I became so irritated. And that's irrational. Like, it was just a little thing. So what's happening in my space? What's happening in my mental health right now? That little thing triggered me. I overreacted to that. Certainly the work that you promote and you teach, and, that I also teach is taking that moment to ground, taking that moment to take a deep breath, stop what you're doing, reflect what you're doing, and practice that, because you never know when you're going to need it. And that's the whole thing, right? You have to have a practice, because then in the middle of the gym, when things are really going crazy and you just want to explode, you don't. And you don't allow that I'm going to explode energy take you to another place. You contain it right away. But the practice is key to be able to do that.
You teach some continuing education courses on yoga through a company that you have called yogianatomy.com, which everyone can check out. Mm-hmm. Is there research supporting yoga for health professionals with regard to burnout, or have you seen that in your own participants where they thought they were coming in to learn a little bit about yoga and wound up learning a whole lot about themselves and started to take some of those skills and bring it back to their own practice?
Yeah, so no literature per se in healthcare providers taking yoga, whatever dose you want, and they're better for it. The yoga literature is looking at healthy individuals. There have been some studies with teachers with doing a yoga or a meditation practice. However, the answer to the second part of your question about have healthcare providers come to the course and realize that they end up learning strategies and techniques for themselves, absolutely. And so what we see is that you might come to a continuing education course on how to apply yogic principles into therapy and really want something different for your patients. So some people will come because they just want to know what this, what are asanas about, or my patients are asking me about yoga and I want to know if I can refer them, or maybe I can have better adherence if I incorporate some yoga into my plan of care. And then the other piece about it is there's attention in a yoga practice paid to mindfulness, right? So all movement is with breath in yoga. All movement is with mindfulness in yoga. And how can we take what we do in therapy, where it might be 10 straight leg raises? How do we make that mindful? How do we incorporate the breath into that? And is that yoga? And so people come to the course in that way, and they realize that they can do things slightly differently. And when they practice in our continuing education course, they realize how beneficial it is for them as well. So the courses are very experiential, so that you're not just, hearing about the technique and the science of pranayama or meditation, but you're actually practicing that and then trying to think of ways to be able to get a little bit of that, just maybe a little bit into that therapy session.
Because as they say, the movement can be the meditation, right?
Absolutely. Yeah. Right. But if you're just knocking off, 10 straight leg raises, how mindful is that? Like, you're like, okay, 10, done, right? But if it's, inhale and exhale, and inhale and really tighten up your quad muscle. Okay, now where are you feeling that? Fantastic. Okay, now lower that down. Great. All right. Did you exhale that time? All right, let's do it on an inhale. So those kinds of cues that are so ever present when you go to a yoga class, shouldn't we be doing that in rehab?
Yeah, because what you're talking about, you mentioned, is the cueing.
Yeah.
Cueing happens in yoga classes. Cueing happens in a traditional mindfulness class. And the cueing is probably the most important part.
Absolutely.
Because that's the skill, right? That's the skill of the practitioner or the instructor or the teacher helping you.
Mm-hmm. That's absolutely right. Today in class, we were doing squats as a precursor to plyometrics, as a precursor to, skills,
That's a fun
agility.
PT class. That's a fun PT class.
Exactly. So students who are just sort of learning the cueing, right? They're just sort of practicing looking, right? And they're missing a whole lot of stuff. They're missing the drift of the knee, and they're missing the landing of the foot and where the hips are going. And then once you point it out to them and they see it, then there's a whole other skill set by how to cue it. Mm-hmm. They don't really kind of know what to do, and then along comes a skilled lab TA who says, just push your thigh into my hand right here. Okay, perfect. Now just leave it there. Okay, great. And now go ahead and do your squat. And they think it's a miracle, right? Because all of a sudden, everything has changed. Well, that cueing was all that person needed. The students were stymied by it. But that master clinician came in and did that, the right cue at the right time. And in this case, the student learned how to do that. I think sometimes in rehab, when we just let things go, when we're just talking about how many sets and reps and what the next end game is, we kind of, it's not the what, it's the how. Mm-hmm. And the how can be so powerful, particularly when it comes to, motor control, but also when it comes to managing pain or exploration of other movement patterns that can be helpful for people who need to find new ways to move.
Yeah, the cueing is the unspoken science that I don't think of course, there's not a separate class on this, at least to my knowledge, in PT school. And maybe there needs to be a whole section of a class. But even I think of like continuing education courses, like cueing is just something we almost take for granted. It's a skill we develop. Some people may not develop it so well. Mm-hmm. But I think tied into some of the more contemplative practices, cueing is very, very important.
Right. Well, that's a piece, Joe, that we definitely don't do well in PT school, right? There's essentially no contemplative type approach to working with patients or clients.
I'm very happy that you've said that, because I think, some of my work focuses around some of those areas, mm-hmm. But let's just touch base on that for a moment.
Okay.
So we're in this world now of biopsychosocial care. PT programs are 3 years long, and there's definitely, when you go into the CAPT accreditation standards, behavioral approaches to patient care are present.
Yes.
Although CAPT standards are just guidelines, so there's no specific bullet point of what we should be teaching. Mm-hmm. If you had a magic wand, Ellen, knowing that you have some expertise in contemplative yoga and mindfulness, how would you start to, and you may be doing some of this, but how would you ideally like to see those principles worked into a PT program or course or the curricula?
Yeah, I think that a way to start is to have students learn those practices personally. So have them begin to understand and practice mindfulness and meditation, because the change that occurs in an individual, it can be profound. Okay, I don't know where you put that into a PT program, but I do think that it is important for that step to be taken. I then think that there needs to be not just an acknowledgement of the biopsychosocial model from a model standpoint, but that it needs to be incorporated into every patient case that is presented. Mm-hmm. And I find that to be extraordinarily challenging myself. And that is because I'm the courses that I teach are part of a large, couple year curriculum. And I acknowledge and accept the fact that students are needing to learn terminology first, and they're still deciphering even into the second and third semester, right? They're still trying to figure out what's the difference between active assisted range of motion and range of motion, right? So there's that, never mind the more complex terminology. And then they're trying to learn some hands-on skills. So they are very much like, where do I put my hands? How do I move? All of that. How do I guard? How do I do gait training? There's so much skill. And now you're asking them to do it in an informed, mindful kind of way. It's a big ask, Joe.
It's a lot.
It's a huge ask. So I'm optimistic that we can get to some students, and I'm optimistic that we can, inform curricula in that way. But I don't know whether we get to 100% of the students, 100% of the time to be thinking about that. The one thing that I've been talking to a lot of different groups, I'm on a lot of different committees and things about the biopsychosocial model. Joe, it's been around for 40 years. Right?
I know, it's not new. Everyone talks about it like it's a new thing. And I'm like, it's been around a long time, people.
It's been around a long time. And I'm on committees with medicine and dentistry and nursing and things like that. And it just befuddles me how we're still talking about that. And so if we really put the patient in the center, and we're really talking about how many different professionals need to be in an axis of care, right? Then why do we still have MDs being the gatekeeper? Like, why is that? Well, it is because of how things get reimbursed. It is because of how here in the United States we interpret what healthcare is. And we interpret what healthcare is based on insurance. Because when you go to other countries and you don't have that kind of hierarchy per se, people with mental health concerns get referred to physical therapy as quickly as they get referred to a counselor or a psychologist, because it's accepted that movement and mindfulness, which are taught by physical therapists in other countries, is going to be helpful for the patient. But we don't do that here.
I love that you said that, because right now there's this perception, okay, we have the biopsychosocial model. We're identifying that there are psychosocial factors that are a part of this person's pain experience or a part of their overall health. But if it's a psychosocial problem, or they have a mental health condition, more specifically, then they get referred out.
Right.
And I've been doing this for a while now. My strong stance toward physical medicine professionals of all sorts, including PTs, is that, well, you may need a mental health professional to be part of your team, definitely. So collaborate. But realize a lot of what you do, the somatic experience that someone has with you, can have a profound impact on their pain, their health, et cetera, stress, et cetera, et cetera. But that's not really spoken about anywhere in PT, really. To my knowledge, I'm a little bit of I graduated in 1996. So when my memory of school, it wasn't really spoken about that, although I will say there's a professor in my program, Terry Hoagland-Miller, who studied Feldenkrais. And Feldenkrais is a very mindful movement somatic approach. And she was pretty much the lone wolf at that time. Mm-hmm. But coming from some of the backgrounds I had with movement, things like that, I was like, well, what she's saying makes perfect sense.
Absolutely. But try to do a Feldenkrais class in PT school.
Well, we did it, and it was not taken well.
Exactly. Speak to someone who has tried. Okay, so you're exactly right. What happens in particularly the Scandinavian countries and Australia or whatever is that psychosomatic is fact. It is where the mind and the body work together. And if you say psychosomatic here in the United States, people respond to you as though, so you think it's all in my head. I really don't have anything wrong. No, actually, what psychosomatic means is there's a connection between the mind and the body.
Yeah.
And the nervous system, is what connects the mind and the body. So we can find ways through different practices to affect the mind, which will help the body, and also the body, which will help the mind. Mm. But here, it has such a negative connotation that people just will put up a barrier. You don't believe I have pain. You don't believe I have a problem because you think it's all in my head. And that's really not the intention. The intention is to accept the fact that these are tightly wound together, and that when you take a rehab or a therapy approach that blends the physical with the emotional, that's where you're going to get a lot of success.
Yeah, really well said. And the two areas that I believe will change that for us as PTs, and I know there are definitely physical therapists working in this area and share the same belief and perception that we're talking about, but obviously chronic pain being one, and then PTSD, which when you look at a lot of the research around it, pretty good research that just top-down mechanisms are not enough to help people with PTSD. They need more of the body somatic work, which we fit really well into, right? We have tremendous skills in that area.
Absolutely. Yes. And I think that you can go and become a yoga therapist. You can go and become a Feldenkrais practitioner. Name another one, Traeger, name a complementary therapy approach that is a mind-body approach, right? And there are, by and large, very good outcomes for some of those approaches. And what do? It's movement, right, linked with intention. And we already, as physical therapists, can do the movement really well. We can analyze movement, we can fix movement, we can tap here, we can say this. So isn't just the next step for us to be mindful about it, for us to get people to engage in a cognitive way in that movement, in a mindful way of that movement? That's the missing piece, in my opinion.
Yeah, really well said. And maybe one day we'll revolutionize the PT curricula in another dramatic way and bring it through another revolution or a wave of change, which it sounds like, you and I are both on the same page as that. And it's been great chatting with you today. As I mentioned, everyone can find more information out on your website. It's called yogianatomy.com. That's yogianatomy.com. Lots of great continuing education courses there. As we close, tell people how they can, of course, learn more about you, but some of the new things you have set up as we move into 2021.
Yeah, so I think, 2021 is not 2020. So that's a very good thing. There have been opportunities to do some online teaching. I've had an opportunity to collaborate with physical therapists in Mexico and South America because there's a big movement in increasing the awareness of the role of physical therapy in people with mental health concerns, as well as mental illness as a primary diagnosis, so schizophrenia, bipolar disorder. So I collaborate a fair amount with the Department of Psychiatric Rehab at Rutgers and work with clinicians there so that we are able to work with clients with serious mental illness in a way that's informed and includes some movement. So what we're working on right now is developing a series of videos that will be available to clients, but also another set of videos that will be developed to help healthcare providers in mental health. So there is a big concern about those healthcare providers in mental health and their state of mind, their level of stress and their level of burnout. And so we're looking to, we've already done some focus groups and gotten some feedback on some preliminary things that we've done. And so we'd like to put together a series of those kind of videos to make it available through a network of healthcare providers in mental health.
Incredible. Great work you're doing. And again, everyone can learn about that work at yogianatomy.com. Make sure you take this episode and share it with your friends, colleagues, and anyone interested in burnout, yoga, chronic pain, PT school, all the things we've been talking about on today's episode. Share it with your friends and family on Facebook, LinkedIn, Twitter, or in a group such as a Facebook group where people are talking about these topics. Dr. Joe Tatta, as always, it's an honor to be with you, and I'll see you next week.
Thank you, Joe. It's been a pleasure.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit Integrative Pain Science Institute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.